Dear friends, good evening. I am Dr. Chandrasekhar Meshram, Chief Coordinator of Public Education Activities by Indian Academy of Neurology and President of Tropical and Geographical Neurology Specialty Group of World Federation of Neurology. And therefore, on behalf of World Federation of Neurology and Indian Academy of Neurology, I welcome you all for this session. At the outset, I convey my best wishes for World Brain Day. We at Indian Academy of Neurology have been celebrating World Brain Day with great enthusiasm since its inception in 2014. This is the 8th World Brain Day. The theme for this year is multiple sclerosis. We have been organizing public education activities for last 30 years, but we did not have a chance to have a session on this particular theme, and therefore today's session has a special importance. And we are very fortunate to have two important personalities who have spent their life for the study, research, and welfare of patients of multiple sclerosis. We have President of World Federation of Neurology, Professor William Carroll, who is currently the Clinical Professor of Neurology at the University of Western Australia, and he is consultant neurologist in the Department of Neurology and Neurophysiology at Sir Charles Garendon Hospital in Perth, Western Australia. He has served in various capacities, including first Vice President of the WFN, and he's a chair of Global Neurology Network, which is again very active in organizing public education activities. And he very successfully had organized the WCN in 2005 in Sydney. And for last 40 years, or more than 40 years, his principal area of research and publication activity has been in multiple sclerosis and optic neuritis and neuromyelitis optica spectrum disorders. And he has been the editor of the Journal of Multiple Sclerosis for Asia Pacific region, and he has received many awards, and I have a great pleasure in welcoming Professor William Carroll. We also have the senior neurologist, a father figure for India, Professor B.S. Singhal, who is Director of Neurosciences at Bombay Hospital Institute of Medical Sciences, Mumbai, India. He has been the Vice President and Regional Director of Asian and Oceanian Association of Neurology from 2004 to 2008. And he's a founder of Parkinson's and Movement Disorder Society. And when he was the President of Neurological Society of India in 1986, he delivered the presidential oration on the theme of multiple sclerosis. So he has a huge experience of multiple sclerosis in this area of multiple sclerosis. And as far as India is concerned, he is the last word on this particular disease. So we are very fortunate to have him. He has received various awards, including the BCIR award, and has more than 200 publications in national and international journals. And his main area of interest is multiple sclerosis, Parkinson's disease, and myasthenia gravis. Welcome, Professor B.S. Singhal. And I also have a great pleasure in welcoming President of Indian Academy of Neurology, Professor J.M.K. Murthy, who is Clinical Director and Chair, Department of Neurology, Care Institute of Neurosciences, Care Hospitals, Hyderabad. President-elect of Indian Academy of Neurology and Consultant Neurologist at Bombay Hospital, Dr. Nirmal Surya. Secretary of Indian Academy of Neurology and Director of Neurology, SRM Institute of Medical Sciences, Chennai, Dr. U. Meenakshi Sundaram. And I also welcome experts in the field of multiple sclerosis who are the panelists for today's session. Dr. Lekha Pandit, who is Professor of Neurology and Director of Center for Advanced Neurological Research in NITI, Bangalore, Karnataka. Dr. Rohit Bhatia, who is Professor of Neurology at All India Institute of Medical Sciences, New Delhi, and he's a convener of Neuroimmunological subsection of Indian Academy of Neurology. Dr. Dheeraj Khurana, who is Professor of Neurology at my alma mater, Postgraduate Institute of Medical Education and Research, Chandigarh. Dr. Netravati, who is Additional Professor of Neurology at National Institute of Mental Health and Neurosciences, Bangalore. Dr. Tapas Kumar Banerjee, Medical Director and Chief Consultant Neurologist, National Neurosciences Center, Calcutta. And the moderator for the session, Dr. Sumit Singh, who is Director and Head of Neurology, Institute of Neurosciences, Gurgaon, and he is also an EC member of Indian Academy of Neurology. So with such experts in the field, I am very sure that you will have a very enlightening session on multiple sclerosis. Just now we have finished a very interesting session by World Federation of Neurology, and Professor William Carroll was there for that session. And it was an educative, very educative session on multiple sclerosis on the occasion of World Brain Day. And another session by Dr. Nirmal Suya is ongoing at the other site. And once again, I welcome you all for this session and request Professor William Carroll, WFN President, to deliver his address. Professor Carroll.
Thank you very much, Dr. Meshram. World Brain Day 2021, titled Stop Multiple Sclerosis, is this year's World Brain Day. As you have heard, this webinar is being hosted by the Indian Academy of Neurology, and the World Federation of Neurology is delighted to join the Indian Academy in this endeavour. We're also delighted to be involved in this webinar, which has occurred in parallel with that from the World Federation of Neurology and the Multiple Sclerosis International Federation. The World Federation of Neurology is most grateful to the resources and energy that the Indian Academy of Neurology and its president, Dr. J.M.K. Murphy, and also Professor Bim Sen Singhal, Director of the Neurosciences Bombay Hospital Institute of Medical Sciences, and the other distinguished colleagues here today have devoted to this World Brain Day. Together, we are all indebted also to the efforts of Dr. Chandrasekhar Meshram for his effective coordination of this event, which will feature a panel discussion on multiple sclerosis and promote this issue. World Brain Day for the World Federation of Neurology and its member societies, including the Indian Academy of Neurology, represents a celebration of the foundation of the World Federation on July 22nd, 1957. It has a mission to foster quality neurology and brain health worldwide. As you've heard, this is the 8th World Brain Day. In recent times, each World Brain Day has, with the WFN, focused on a specific disease, and we've been fortunate to partner with a member of the Global Neurology Alliance, like the International Headache Society, the World Stroke Organization, the International League Against Epilepsy, the International Parkinson's Disease and Movement Disorders Society, to mention a few. This year, the World Federation of Neurology has partnered with Multiple Sclerosis International Federation to join what is an extended World Brain Day campaign from today through to the World Congress of Neurology in October. Turning to the theme of this World Brain Day, some key facts about multiple sclerosis, which I'm sure will emerge during this session, are firstly the disability that multiple sclerosis has attached to it. It's a debilitating neurological disease that impacts every aspect of a person's life, with effects ranging from cognitive impairment through to significant physical disability. In many instances, this progression of accrual of disability has been inexorable. Throughout the world, at the latest count, 2.8 million people of all ages are affected by multiple sclerosis. And every 5 minutes or so, someone will receive this diagnosis. In the area of access to treatment, however, there's been dramatic changes. In the last 25 years, the world of MS has been transformed by the steady succession of ever increasingly effective disease-modifying treatments, or DMTs. Currently, highly effective treatments suppress inflammation so well that they not only prevent sustained disability progression, but the innate repair processes are able to result in sustained disability improvement. The tragedy, however, is that while such treatments are widely available, they are relatively restricted and inaccessible, even in some high-income countries. The situation is worse in low and low middle income countries. The prohibitive cost of these medications prevents widespread accessibility and, as a result, condemns people with multiple sclerosis in many low middle income countries to levels of disability no longer seen in more affluent countries. The challenge, therefore, is to identify and render available a range of effective treatments in the same way as the COVID-19 vaccines have been distributed. Together with those in the Indian Academy of Neurology and those watching, the MSIF and the World Federation of Neurology, we must advocate strongly for governments, the World Health Organization, and pharma to develop supply and distribution chains to those currently excluded from effective disease-modifying therapies. In the area of education, we must work with healthcare professionals to recognize the signs and symptoms of MS so people can be diagnosed early and more effectively treated. In the area of advocacy, which is the basis of this session, we can stop multiple sclerosis by diagnosing earlier, by providing better access to life-changing treatments, and by advocating for quality of life for those living with MS and their carers. So in concluding, I'd like to thank you for joining this webinar, for participating in the webinar, and for joining the activities of the World Brain Day to advocate for improvements in access to effective treatments, support and care for those living with MS, so that together we can halt MS-caused disability, reduce the threat of being disabled, and improve the lives of those with MS. Thank you very much.
Thank you, Professor Carroll, for this important words of wisdom and giving hope to the patients of multiple sclerosis. Now I request Professor J.M.K. Murthy, IN President, to say a few words.
Very good evening. Welcome to all the panelists, and I have the pleasure to welcome Professor Carroll and Professor Singhal to this webinar being organized by the Indian Academy of Neurology. As decided by the World Federation of Neurology, we will be celebrating this day as Stop Multiple Sclerosis. And the panelists are experts in the field of multiple sclerosis. I request all the attendees to feel free and ask questions to the panelists and clarify their doubts. Over to Chandrasekhar.
Yeah, thank you, Professor Murthy. Now I request Professor B.S. Singhal to inaugurate the session and address.
Professor William Carroll, President of the World Federation of Neurology, Dr. J.M.K. Murthy, President, Indian Academy of Neurology, Dr. Chandrasekhar Mishram, Coordinator for Public Educational Activities, panelists, friends, very good evening. Professor Carroll, in fact, has highlighted all the important aspects of multiple sclerosis. It is a very great pleasure that the theme for this year of the World Brain Day indeed is multiple sclerosis. As you know, even in the Indian context, we are diagnosing much more because of the easy availability of the newer tools like MRI at affordable price, and also increase in the number of neurologists. Even then, the number of neurologists cannot cater to the needs of the country. It is very important that the advocacy that he emphasized upon, we also teach the medical students, the physicians, also to recognize the symptoms and also increase the awareness of multiple sclerosis in the country so that the diagnosis can be made early, the disability can be prevented, and I do hope that the drugs will be available to the needy. Till now, many of the patients could not really afford any drug, but now at least with the help of the pharma companies, some of the drugs have been made affordable. So I do hope that with this session, there will be an outreach and more awareness about multiple sclerosis amongst all. And also I'm very pleased that the Indian Academy has invited the experts in the field of multiple sclerosis to have an important panel discussion. So thank you very much indeed. And it's a great pleasure to inaugurate this webinar on multiple sclerosis. Over to you, Dr. Meshram.
Thank you so much, sir. Now we move on to the panel discussion, and I request Dr. Sumit Singh to take over. Dr. Sumit.
Good evening, everybody, and a warm welcome to all the panelists and the people who are attending this webinar. Am I audible?
Yes.
Yes.
Okay.
You are.
So there would be a little introduction as to how I want to conduct this event. So I'll be asking questions pertaining to the diagnosis, management of multiple sclerosis, and with special reference to the current COVID pandemic. If there are any questions which are arising from my questions and the answers given by panelists, please post it on the Q&A box. We'll try to address as many as possible. I will ask the question to one of the panelists at a time, and if there is any added information which any other panelist would like to attach, then most of you are welcome. So this is how I have planned this flow of the event. So my first question is to Dr. Lekha Pandey from multiple sclerosis expert.
Not audible.
So, ma'am, my first question: how do you diagnose it? My first. Am I audible?
Yeah.
Yeah.
Not well. Okay. Your sound was getting broken.
Yeah, Sumit, you can put off the video. I think that will
Yes,
be
sir. I have done that, sir. I have done that. What is multiple sclerosis and how would you diagnose it?
So is this addressed to me?
Yes, ma'am. Yes,
Okay.
it is to Dr.
Yeah.
Lekha Pandey.
Okay,
Yeah.
so
Yeah.
in simple terms, the way I would describe multiple sclerosis to my patients is that it's a chronic disease that basically affects you by attacking the coverings of your nerves. That's how I explain it. I know it's not necessarily translates into, accurate medical information, but still I will tell them that the myelin coating, it's like, the normal insulation of an electrical wire that gets destroyed due to inflammation, a kind of allergy which attacks your own system. In this case, the coverings of your nerves, which is the myelin, and that leads to loss of myelin, which is, in other words, means demyelination. And that in turn will produce clinical symptoms. And the site of involvement will determine what kind of clinical presentation you're likely to present with. So this is a disease which affects all parts of the brain, can affect all parts of the brain, can affect your optic nerves, which are important for your vision. It can affect the portions of your brain which control your balance and coordination. It can infect your spinal cord and give you symptoms like numbness, tingling, weakness, or it can even produce bladder disturbance. So these attacks usually tend to occur in young people, particularly in women, and usually in the second and third decade of your life. And they can be precipitated by an infection, which may not be a known infection. It can be just a viral infection, or it might occur de novo without any prior known event. Sometimes it occurs immediately after your delivery of your child. And once it occurs, it has a tendency to come back again and again when it's known as relapses. So early on, each relapse may be treatable with interventions and you will subside back to your normal state. But over a period of time, if it's not treated with the appropriate medication, what Professor Carroll referred to as disease-modifying drugs, these disabilities may not completely go away and you accumulate disability over time. But fortunately, there are so many experts now in India who recognize the disease. And when you present with your symptoms, they would do an MRI scan, followed by a series of blood tests, also a spinal tap. And sometimes, and based on all that, they are able to diagnose MS very early. And if the appropriate medications are started, you can lead a very good life, provided you visit your doctor on periodic intervals, keep in touch, and are compliant with the medications the doctor gives you. So that would be the face of MS as we see it now. And that's how, yeah.
Thank you, Dr. Lekha. My next question is to Professor Rohit Bhatia from All India Institute of Medical Sciences. Welcome, Rohit. So, as Dr. Lekha has already told, that multiple sclerosis is a disease in which you would keep on having attacks of focal neurological deficits. And trained neurologists can easily diagnose multiple sclerosis by doing some investigations, which might include an MRI, some blood tests, maybe a lumbar puncture to look for the mimics of multiple sclerosis or some other markers for multiple sclerosis. Once you have made the diagnosis, then what would be the treatment plan for these patients?
That's a good question, Sumit. I think most of the patients, when they come, they have two basic questions. One is that do they have MS as the diagnosis? And if they have it, then what should they do next? So on a broader perspective, people come to us with two components of the disease. Once when they come to us with the first attack or the first event.
Rohit, please speak little louder.
Okay. Am I not heard, sir? Am I heard?
You are heard,
The
but
voice is quite low.
Yeah.
Is it better now?
Yes, now.
Yeah, now it is.
So I said that for patients, they generally present to us with two scenarios. One, when they come to us with the first event, and the second, when they already have had more than one event in the past. At present, with the advancement of the diagnosis and ease of making the diagnosis with defined criteria, we are able to diagnose patients even after the first event by using a set of clinical parameters, imaging, and other supportive tests like CSF. So if you've been diagnosed as a patient of MS, your doctor will discuss with you the need for starting long-term treatment with a goal to keep you stable, with a goal to keep you relapse-free, and a goal to keep you disability-free. So the aim would be to have you disease-free with whatever best possible efforts that could be made. It's a continuum of decision-making and it's a continuum of treatment. So these particular medical therapies are known as disease-modifying agents. They come as oral formulations in form of tablets, and they also come as injections. When we discuss with our patients, we of course tell them the available options. We discuss with them the potential risks and the benefits of taking the treatment, and also discuss with them the cost. Fortunately, over a period of time, with the availability of the generic medications or the ones which are now manufactured within the country, the cost has become relatively a less limiting factor for decision to start treatment upfront. However, for people who are not responding to a set of treatment, we may have to go to slightly more effective therapies, which may be a bit more expensive and which may not have generic formulations as well. So broadly, there are two conceptualized perspectives of treatment. One is what we call the standard approach, which is the escalating approach, where we start with a moderate efficacy drug, which has relatively more safety and is a tolerability and less burden to the patient. And then we move up the ladder depending on the need of more effective therapy. Or if we have a patient de novo whose disease looks a bit more aggressive from the beginning, who's had multiple episodes, and whom we feel has already started to have some findings of disability of any kind which the patient perceives, then we may have to straight away start with a more effective therapy or a more stronger therapy in simple terms for the patients to understand. So we have many medications now available. We have a wide landscape of medications available. And all I would say to the patients or the people who have been diagnosed with MS, that it has gone very far and wide in research, and we have many effective therapies which we can choose from. So we are very positive about treatment, and we feel most of the patients do very well. If they come on time, they are diagnosed early, and they start on a medication, and they're compliant to the medication. I think that's what I would say in a nutshell, Sumit, about this.
Yeah, thanks, Rohit. So we would have two types of treatments. One would be a treatment for an acute attack, which might be steroids or maybe something other which modifies the immune system for that particular attack. And then to prevent further attacks from happening, these patients would probably require some disease modifying agents. So what I do is I usually offer these patients a cafeteria choice in which I tell them about a possibility of what are the options available, and then take them into confidence and then come to a conclusion that this is probably the best suited DMA or disease modifying agent. Dr. Dheeraj from Chandigarh, welcome Dheeraj. So what would be your approach when you are discussing the possibilities and the options of DMAs to patients?
Yeah, hi Sumit, and thanks for this question. More or less, the discussion remains the same, and we use this principle of SDM or shared decision making, like you specified. However, the approach which I usually adopt, I tend to go more aggressive in the beginning and use rather than escalate. I tend to use a initial pulse, or not just a pulse steroid. I tend to use a high efficacy treatment, depending upon, of course, the course of the MS. So looking into those, usually what I would prefer is go point to point, talk to the patient, tell them that what kind of disease activity they are usually experiencing. For example, if it's a male or a female, that starting from the gender, starting looking at their risk factors. Is the patient obese? Is the patient diabetic? Is the patient a smoker? So all these things. And first of all, actually, the first thing that I usually use before I really latch on to the treatment or go on to the treatment is counsel them first about what MS is and what are the current available treatments and what are the current outcomes that we perceive. So education really makes a lot of difference in their acceptance of the treatments. And like I said, looking at the prognostic factors, we also tell them, in simple terms, what are the values of the OCBs, as we now know that OCBs indicate a higher degree of activity down the line, down 1 year downstream. The number of attacks, of course, and how was the relapse? For example, was the relapse a severe relapse, or was the relapse a milder relapse? And how was the recovery from the relapse? If the recovery of the relapse has not been complete versus a relapse which has been complete, we take into account all these factors. And if I get, and invariably, what happens is a patient who seems to have maybe even a single attack or 2 attacks, and if I look into the factors which indicate aggressive versus non-aggressive disease, most patients would carry more than one factor. A male, he would have possibly an OCB, he would possibly have a poorly recovered relapse and involvement of brainstem and involvement of the cord. So these things, I've seen them happening quite much in combination. And even if I get 2 or 3 out of these multiple factors, I would offer them a high efficacy treatment in the beginning and hit hard right in the beginning rather than starting more platform therapy. So that's one approach which I currently adopt, and it has been now well exemplified with number of studies which have shown that if we go hit hard early on to the disease, it definitely leads on to better outcomes in terms of disability progression. So that's my approach to treating patients with MS.
Yeah, thanks, Dheeraj. Dr. Tapas, good afternoon. Good evening, and welcome. So there is a question which has popped up from the viewers, and I think it's a very pertinent question. And that is about a female who was, say, 28 years old and has developed optic neuritis. She was treated well with the methylprednisolone and improved. The vision came back to normal. When the MRI was done and other investigations were done, it was highly suggestive of multiple sclerosis. She is recently married and she wants to have a child, and she's on dimethyl fumarate. So what would be your advice to this lady?
Well, thank you very much for the question, Sumit. This is a young lady who is going to get who has got married and going to have a child. I know there are 2 sets of medicines which can be given even while the patient is pregnant. That is, one is glatiramer, another is the interferon you can give. Because if the patient is on teriflunomide, I suppose you have to withhold treatment when the patient gets pregnant, and once the pregnancy is over, we can restart the medicines. So I would give them the choice that these are the, if you want to carry on the treatment, even while you are pregnant, I would suggest to start them with glatiramer acetate or with interferons, which probably has a safer options during pregnancy. But you can, if the patient is not in a very mild form of multiple sclerosis, you can even withhold treatment, because in pregnancy, they are well protected. They don't have any relapse or any aggressive form of disease during pregnancy. But once the child is delivered, then maybe there is a relapse. You can initiate treatment at that stage. So the options can be given, and you can withhold treatment if the patient is going to get pregnant soon.
Dr. Netravati, welcome and good evening. My question to you is, do the patients with multiple sclerosis have a higher risk of COVID-19? And the other way around, if a patient has had a recent attack of COVID-19, does he have a higher chance of developing a relapse of multiple sclerosis? And any changes to the current treatment options for patients with MS during the pandemic?
Good evening, Dr. Sumit. So among the 3 questions about the interaction of the COVID with MS. So initially, I think when the pandemic started, all of us, the panelists, I think we were part of the task force to discuss about the same issues. And that time we had a little knowledge only to know as to what is the interaction. So based on the mechanism of action, there were a lot of postulates and there were a lot of guidelines issued by multiple societies of MS to guide us as to how we should be managing. But now over the last 1.5 years, I think most of us have become quite knowledgeable in knowing that one thing is many of these people are on disease modifying agents, and some of them may be on immunosuppressants, as one of the question is asked on about azathioprine mycophenolate. So the fear is whether these people who are on disease modifying agents and immunomodulators, are they of increased risk to have COVID? What we have seen is that they are not of increased risk to have COVID. It is like a double-edged sword maybe the disease modifying agent is protecting them against developing the COVID as well as, but if their high disease activity is there and if they are on high disease modifying agent, there are few studies which have shown that yes, they can have developed a severe COVID, especially with the anti-CD20 therapies which are there. But otherwise, there is not that much literature now available to show that there is an increased risk of COVID. That is one thing. And if the patient is having MS, is the patient going to develop severe COVID? As I said, it again depends on the initial, how much the disease is under control. They say that if they have a high disease activity and lot of spinal load and they're bed bound, then upon that, if they develop COVID, there is a slight chance of increased activity. Otherwise, if they are active, if they are practicing safe measures just like any other person with non-MS, I think the risk is almost the same. Then the third thing about the disease modifying agent and the interaction with COVID, the disease modifying agents have been classified based on their affinity to develop COVID related complications as low, moderate, and severe. So in the low category, we have the first line agents like the interferon, the glatiramer, as well as the extended interval dosing natalizumab. So these people have a very low risk and they do not have the higher risk of developing COVID. And even if they develop COVID during treatment with this, there is no problem. It can be continued. Then comes the moderate degree disease modifying agents like the usual degree of usual 4 weeks dosing of natalizumab. And then sometimes the initially if their disease is under control and fingolimod is given. Fingolimod, two papers suggest that because it also has an effect on COVID, it may be a little bit of protective, and few of them show that if they are having lot of low cytopenia, that is low blood counts, then they may be at an increased risk of COVID. That is the thing with fingolimod. Otherwise, the other thing is the moderate degree. Then coming to our severe degree disease modifying agents like the alemtuzumab, the fingolimod against saponimod, and anti-CD20 therapies. Of course, we do not have ocrelizumab here, though there are 1 or 2 people who are on that. Rituximab, especially, it is there are a lot of papers which have come up now that though we are now comfortable in giving rituximab, we have seen that the risk of developing a severe COVID and a hospitalization is more with these anti-CD20 therapies, more with rituximab and ocrelizumab. But that does not mean that we should not be giving this, because most of our patients are on rituximab. So what we need to tell them is that once they have received these anti-CD20 therapies, they need to have little bit of behavioral modifications, especially in the first 2 to 3 months, so that the risk of developing COVID severity is in during that. But after that, it wanes off. This is the way we usually tell them how they should be dealing when they are going to be exposed to COVID. But otherwise, the main thing what we need to stress upon is the myth that these people are on immunosuppressant and they're at increased risk of developing COVID is no more there. Now we are more comfortable in knowing how the interactions are there and we can advise the patients accordingly. So definitely we'll be able to prevent the severity of the COVID infections in these patients. Thank you.
Thanks, Dr. Netravati. Dr. Lekha, what would be your usual protocol for following up these patients with multiple sclerosis? And what would be your schedule? And what investigations would you be advising to these patients once they come for their follow-up?
So to answer your question, first of all, I must say that I work out of a medical college hospital, which sees low-income patients. So cost effectiveness has to be there for anything and everything I do. The second thing is that I run a registry. So I have a uniform protocol-based management of these low-income patients. So what happens initially after I've diagnosed, I've started treatment. My patients are on follow-up every 3 months telephonically with my clinical coordinator. And when there is a specific need, they reach out to me through her and I would speak to them. By and large, if the patient has gone home with some therapy, I would call them back once after 3 months after the patient has gone home. And then I would call them every 6 monthly if they can come. But once a year is mandatory because that's when I would do my yearly scans. If they are doing well, otherwise a yearly scan is what I would do. But I would like to see them at least once every 6 months simply because I like to follow up with non-invasive and non-expensive investigations like an OCT-VEP, which is part of my study protocols and my research protocols, which I do for them subsidized or free if they are too poor. So first 3 months, then after 6 months if possible, and then yearly. Yearly scans help me basically decide how I'm going to proceed further. If a person comes to me with history of more than 2 relapses in the interim period of 1 year after starting treatment, and if there are new lesions that support that, I would like to change the treatment within the first 2 years. Definitely, I would like to change course for that patient at the earliest based upon these criteria. So that also helps me in terms of how I follow them up in the ensuing years.
Okay, so there is a specific question to Dr. Rohit Bhatia, and that is what would be the role of the less costly immunomodulators like azathioprine and mycophenolate mofetil as compared to the more costlier options of interferons, dimethyl fumarate, fingolimod, and the likes for disease modification and multiple sclerosis?
Good question.
This is from the audience.
Good question, Sumit. So we have actually transitioned over the time, and what has happened relatively good for us is the availability of many of those expensive oral medications, which are now available as generic formulations also. So broadly speaking, any drug which acts on the immune system, I mean, believing that multiple sclerosis is thought to be a disease which is autoimmune, which means that your own cells start to recognize your own tissue as abnormal. So it's kind of a self-destructing, but we do not know what are the inciting factors for that. So whenever you have an autoimmune condition, broadly speaking, you are treated with medications called immunomodulators. So the drugs which modulate your immune system to stop them to malfunction or misbehave, or even if there is an inciting factor, they keep the systems under control. It's like taking an anti-allergic medication for someone who has a frequent attacks of allergy. So we'll keep those systems down to malfunction. So one of the group of those drugs which are used as broad spectrum for many conditions in medicine, neurology, gastroenterology, rheumatology, and so on, are called immunosuppressive medications. They suppress the immune system. Two of those most frequently used agents are azathioprine, and another one is called mycophenolate mofetil. Both of them are available as oral tablets. And for many years, we've treated many of our patients on using these two agents, especially when patients are not comfortable in taking injections, or when the oral formulations like dimethyl fumarate and teriflunomide were yet not available, or when they started to be available, they were very expensive for patients to buy. And there were patients who were not comfortable in taking interferons because the cost was almost like 25 to 30,000, or average 15 to 30,000 a month. So many of those individuals, I think amongst all the panelists sitting here, would have experience of giving them the option of treating with azathioprine or mycophenolate, because logically they are immunosuppressants and they will definitely should work. And we have evidence from the literature, even for in the past many years, that these drugs are not ineffective in managing multiple sclerosis. So their room still exists for some people for whom cost really matters, even for 1,000 or 2,000 rupees a month. With the advent of the generic formulations, the cost of these drugs like teriflunomide or dimethyl fumarate could go as low as to 3,000, 3,500 a month, and ranging from almost 3,000 to maybe 5 to 5,500 a month. Even if you give mycophenolate mofetil to this patient, which would potentially be thought of not a usual drug which people would use worldwide for MS because of its inherent immunosuppressive property, the cost could be almost 6,000 to 7,000 a month. So we have come to a point where we have options to choose from for both immunosuppressive and the immunomodulator drugs, which have less immunosuppressive potential. So if you talk to an individual or talk to a patient and tell him and explain him all the risks and benefits, as Dheeraj had also pointed out on a shared decision-making approach, many of the patients get worried when you tell them that these drugs have immunosuppressive property, not that the other drugs like dimethyl fumarate or teriflunomide don't have it, but when you see them listed among the so-called approved drugs by different medical agencies across the world, we need to tell patients about availability of these drugs as well. So the perspective is wide, and I think we as physicians are responsible to discuss all the options with the patients, and wherever feasible and whichever is suitable to an individual, whether it is azathioprine or it's mycophenolate or it's teriflunomide or dimethyl fumarate, we need to make the choice. Now, you could have a patient who could afford, but is not comfortable with a daily tablet. He says, I'm not compliant, and his family says, I'm not compliant. You need to tell them that there are options with low frequency interferon available. And there are patients who choose them because they can afford and they are more comfortable taking once a 14 days therapy. And there are patients for whom cost really matters a lot. And we may have to choose even azathioprine rather than the other available agents, because for them, 1,000 to 1,500 cost saving a month is critical. So I think it is a individualized approach. And the good thing is we have a lot of landscape to choose from. Thank you so much.
Yeah, Dr. Dheeraj, there are a couple of questions directed to you specifically. We see prescriptions with tons of multivitamins and antioxidants written for patients with multiple sclerosis. So what would be your take on that? And any specific dietary modifications or dietary advices which you would tell these patients, and the role of exercise?
Role of?
Exercise.
Yeah, sure. So I'll take them one by one. Multivitamins, I am in general not an advocate of multivitamins in any neurological disorders, and fortunately, none of the well-planned and well-executed studies have shown any evidence of any vitamins. Yes, specifically in multiple sclerosis, the only vitamin which has a proven role is high-dose vitamin D, which has been specifically proven mainly from data from the West, that having low vitamin D levels does have poor kind of it may indicate, or it may lead on to poorer outcomes. And also lower vitamin D levels in childhood have been associated with a higher chance of having MS in later life. So vitamin D is something that I routinely advocate and prescribe to all our patients, high dose, 60,000 units, which we can give either initially, and also we do baseline levels as part of our workup to look at their levels. Usually it is low in our country. So adequately give them once a day for a few days, 5 days, and then a weekly, and then monthly. There was some hope from a vitamin called biotin, which came up recently for secondary progressive MS. The first two phases of the clinical trials gave very good hope of high dose biotin using 100 to 200 milligrams, which is unfortunately not available in our country. But the first two phases gave us some hope that they tend to improve the strength in secondary progressive MS. And I started using it very rampantly, but now we've had the third phase 3 trial, which came up recently. And the data is very strongly suggestive of no major role. So I've even weaned off patients of biotin. So that was one hope which came up. Apart from that, yes, people do resort to a lot of vitamins. I do tell them that this may not specifically help, but it helps them, regain a psychological advantage as providing them some strength. They are most welcome to do, especially if they're not taking an adequate diet. So diet, as you mentioned, a good diet which is recommended for MS is almost as we recommend for non-communicable or cardiovascular diseases, and specifically in MS2, good vegetables and fruits. These have been advocated. There have been a lot of fads available on the net about eating sardines, about avoiding lactose, about avoiding gluten. There have been no evidence. Emerging data on microbiome studies is still forthcoming, and we ourselves at our center are doing those. So maybe there may be an association of diets in different regions of the country or the world that we may be able to come up with after microbiome or the gut-brain axis tells us whether specific diets, do they lead on to higher inflammation or not in MS. So till that time, I would not say that any specific. A healthy diet, which has a lot of fruits and vegetables, would be recommended definitely. Exercise, the role is clearly the role of exercise is very salutary. It has to be overemphasized for various reasons. One is an exercise for general health. In MS, it clearly plays a very effective role. And now we would categorize it for different kinds of patients. Patient with obesity definitely has to lose weight with exercise, and an exercise program may not be very intensive because intensive exercises may precipitate a relapse. So we tell them moderate exercise. As far as obesity is concerned, it has got a clear bearing to poorer outcomes in MS, and of course having chances of diabetes. So diabetes and overweight both need to be avoided in MS as they reduce they are associated with poorer outcomes. And the second part of exercise, which needs to be highly I would say overemphasized, is in SPMS patients who have gone on either a wheelchair or even are on walking sticks. Their exercise is, I would say, of immense value. The reason is the cardiovascular component goes off. So we need to tell them to take recourse to stationary cycling or exercises which they can do on a stationary basis. Typically, cycling is what we recommend them to do, or any kind of exercise which raises their heart rate, because not only are we putting them at risk of having greater decline in function in MS, we are also putting them at greater risk of having cardiovascular dysfunction, which happens to be also a fact in these patients. So exercise at all levels, at all types of MS, at all stages of MS should never be undermined, the importance of exercise.
Yeah. Thanks, Dheeraj. Dr. Tapas, there are some specific questions directed towards you. One is, suppose a person develops a relapse of MS during these COVID pandemics, when there was, say, a second wave or when there was a first wave. At that time, what would be your treatment protocol? Will it be the same as a non-COVID era? That is one. Second is, would there be any changes in your follow-up protocols of patients during COVID and non-COVID era? And third is the role of delphamprotein in patients with multiple sclerosis who have walking abnormalities.
Thank you. It's a good question. I think in this COVID pandemic, one has to be very careful in starting off the patient on, high-end immunosuppressives like alemtuzumab or even rituximab. I think the safe options during this particular period is probably interferons, the glatiramer. You can give teriflunomide or fumarates, but I think the safer options are those injections. And if the patient has aggressive disease, then natalizumab is also a safe option rather than giving them the B-cell depleters or alemtuzumab. So I think we will choose for those drugs which are safe during this pandemic and ask them to follow these COVID protocols during their behavior, using mask and all those other things. So that's what I do. I tell them that way.
No, I had a couple of more questions.
Okay, we talked
If the
about
patient develops a relapse during this thing, then would you give him steroids?
Yes, that is also very difficult. If they have a mild relapse, of course, you can say if it's a mild relapse, it can, the patient can have remission spontaneously. But if it's quite a significant relapse, we have to give them steroids. There's always a risk that the patient can have COVID flare-up, or you have a worsening of the disease within a few days after giving this pulse prednisone therapy. So mild relapse, I think I will let them go and see if there is a spontaneous remission. If it's a high-end relapse, we have to give them steroids. We don't have any option in that case.
And the third was the role of dalfampridine in patients.
Dalfampridine actually I give in progressive kind of multiple sclerosis. Some people say, okay, they have got, my experience with dalfampridine is not that great. Patients don't say that. They sort of have a tremendous amount of mobility after using this drug. But those with the progressive multiple sclerosis, some patients say they found after using this drug, the mobility is a little bit better. That is my experience with this drug.
All right. Thank you, Dr. Tapas. We have Professor Nirmal Surya, who is the President-elect of Indian Academy of Neurology. I think he's two-timing. He is giving a lecture on the WFN, and he's also present here. Professor Nirmal, sir, are you there?
Yeah, I'm very much there.
Yeah. Welcome, sir. How are you doing?
I'm fine, thank you.
Yes. So I had a question for you, because your primary area of interest is rehabilitation. So what is the rehabilitation protocol for patients with multiple sclerosis?
All right. So, rehabilitation is a very complex formula to give it to the patient with MS. One really need to establish multidisciplinary team, and who is the one who is going to treat the patient first, or who is going to be the part of the team taking the role and lead. Now the challenge comes is, the higher the EDSS, the more the need of neurorehabilitation of multidisciplinary team in those patients. Because if anybody who is above 3 or 3.5, he would definitely require the therapy in the form of physical therapy. And as you have rightly pointed out, the treatment along with physical therapy and multiple problems like fatigue, cardiovascular, age-related problem, though most of the patients are young, so we could take them into a little bit more aggressive therapy. Then comes is developing the skills, modifying their ADL situation at home or at the workplace, so role of occupational therapist. But those patients who have EDS above 5 or 6, they might find difficulty with speech and language. Some of them may have a swallowing disturbance if the predominantly brainstem lesion MS is there, and they would really look after with the speech therapist. Those with lesser EDS and on the disease modifying drugs might have a lot of cognitive disturbance, and therefore a neuropsychologist evaluation in each MS patient at some stage and maybe regularly has to be done, because cognitive problems could be a mood disturbance, depression, anxiety. The other could be memory disturbance, forgetfulness, and they all need to be really taken care in this patient. Then you can have an associated other issues like social worker is required to help them out, wheelchairs, assistive technology. So orthotics might be required in anybody who is above 4.5 or 5 EDSS. So rehabilitation plays a very pivotal role. One need to really require at what stage of disability the patient we are seeing, and who is going to intervene first or second altogether. So that's where, Sumit, we really need to look at. But I tell you, each and every patient, rehabilitation would be a very, very important point, whether it is cognitive, psychological, or motor, or other. Thank you.
Thank you, Professor Nirmal. Dr. Netravati, I am giving you the most important and the most frequently asked question by patients with multiple sclerosis during this era. That is the question about vaccination. So, what would be your answer to a patient who asks you that I want to get vaccinated for COVID-19? When should I get vaccinated? What would be my check boxes which I would be doing before I get the vaccination done? And if I get the vaccination done, which vaccine do I choose?
Thanks, Dr. Sumit. COVID vaccination is a must. Most of the time, I tell the patients the first time we'll have two sets of patients who may come to us. That is, first one is they have come to us in the first clinical episode. Now we have diagnosed them as MS, or they were diagnosed MS, have come with relapse, not on treatment previously. The other is stable patients of MS who are already on treatment. So let me address both of them. So the patient, when they come to us first, if we are able to treat them with the steroid initially and taper off the steroid, I usually ask them to take the vaccine after the effect of steroid is gone, so that the antibody response to the COVID vaccine would be more better before we start any disease modifying agent. Of course, if the patient's relapse is severe and patient has not completely improved with steroid, and we may have to start the disease modifying agent. And if the disease load is not very high, then would try to give a disease modifying agent like the oral disease modifying agent, so that they can tide over the period, take the vaccine, and then switch on if it is required to switch on to a highly disease modifying agent. That is the first thing for a new patient who has come. Coming to the patients who are already on various disease modifying agents, how to time. Always stress upon the fact that vaccination is a must. And many of the time, the question what they ask is, why do I need to take vaccine? Is there going to be a relapse on taking the vaccine because I'm a patient of demyelination? And I was told previously that taking any vaccination could trigger a relapse. This is the question most of them come to. So what we need to stress upon is that all the available COVID vaccines are non-live vaccines. They are killed or a subunit vaccine. None of them are live vaccines. And the risk what was mentioned previously for MS patients are mainly with live vaccines, especially with yellow fever was mentioned previously. So we are not having any of the vaccines which are live. So we should tell them that any vaccine, it can be taken. There is no issue. The risk of relapse is less, especially if they are well controlled with the disease modifying agent. But it has to be timed very properly so that they do not have a relapse. So coming to the interferons, glatiramer, no issue. But only problem is many of these patients can have increased temperature or fever, which can cause a pseudo relapses in them. So always tell them to start the paracetamol prior to giving the vaccination, at least half an hour to 1 hour, and then continue it for 1 to 2 days, especially in those patients whom we know that they have a temperature sensitivity or a Uthoff's phenomenon like symptoms in the past. So that will help them to tide over that period and do not have a pseudo relapse. And on oral disease modifying agents, no issues, whether it is teriflunomide, dimethyl fumarate, fingolimod, no problem. They can continue the medication as well as take the vaccine. Coming to the injectables, that is the anti-CD20, especially the rituximab, I always tell them, give a gap of 90 to 100 days after your last rituximab, and then that would be the ideal time to take the vaccine. But there was a time when we were going through the second wave, and many of the patients were especially working in places where they are highly exposed and they can't wait for the next 3 months. Then at least wait for 4 to 6 weeks if possible. That would be the thing to be told, but if possible, 90 days. And if they're already due for rituximab, wait at least for 4 weeks. That is They take the vaccination, finish both the doses, wait for 4 weeks, and then take the rituximab. So 4 weeks before, or if already taken, wait for 3 months or 90 to 100 days after you take the vaccine. Main thing is it should not be a waste of taking the vaccine, because when the vaccine, if you're taking very close to these anti-CD20 therapies, what happens is the antibody response won't happen. So if we time it well, then the antibody response will happen to the vaccine and they can have the benefit of the vaccine as well as not having a relapse. Coming to the natalizumab, most of them will be at either the standard dose or extended dose, either at 4 to 6 weeks interval dosing. So I always tell that keep a 1 week gap prior and after. That is 1 week prior to and 1 week later, so that there is no issue in taking the vaccine. So most of the time it is addressed like this. I think Dr. Meenakshi has asked about Fingolimod also. Is it same? Yes. Fingolimod, only thing is that if they are well controlled on Fingolimod, there is no problem. Whatever the literature says now, there is no need to stop. Coming to the other agents which are not disease modifying, like azathioprine, mycophenolate, and some people can be on cyclophosphamide. Again, azathioprine, mycophenolate, no issues, but if possible, if the disease is well controlled, just skipping for 1 week to 10 days is not a problem, especially if they've had a COVID in the recent last 2 to 3 months. Otherwise, actually, there is no need to stop the azathioprine or mycophenolate. But I have just only if they have had a relapse or if they've had a COVID infection, then we try to ask them to withhold for 1 week, 10 days, and then take the vaccine. With cyclophosphamide, yes, the risk is slightly higher. Just when the 3 weeks is almost about to finish, that would be the ideal time to take. But otherwise, with cyclophosphamide is a little bit riskier. Then apart from all this, the main thing, the steroids, which we would have given to them. So if they are on steroids, one thing, there is something called as a high dose steroids and a low dose, especially if we have just giving them pulse steroids. Pulse given at every 4 weeks interval, then try to time your vaccine at the 3rd week or the 4th week, especially after 2 to 4 weeks. But if they are on oral steroid, then if they are well maintained, try to come at least less than 20. Otherwise, actually what they is told is that you should try to stop the steroid and then give the vaccine. But there are patients where you can't completely stop the steroid, especially our MOG related patients. In such patients, at least come down to the lowest dosage, less than 20, and then give the vaccine. So that would be, and coming to the last part as to which vaccine is better. We know that what we have, the choices are, one is the killed vaccine as well as the subunit vaccine. Both are quite efficient, but if you want to time your disease modifying agent, giving 3 months interval for a Covishield vaccine would be slightly difficult. Like I've had a patient who's had a relapse, we've given steroid, can't wait for 3 months to start a disease modifying agent. And during that time, we can ask them to go to take Covaxin so that within 4 weeks, they would have completed the vaccination. And then we can ask them to take the disease modifying agent. But otherwise, actually, there is no problem in both the efficacy of between both Covishield as well as the Covaxin and the Sputnik also, which is available now in India. Only thing, if they have a risk factors, uncontrolled diabetes, uncontrolled hypertension, only in those cases, slight preference towards Covaxin. That's all. Thank you.
Thanks for such an elaborate answer. And I'm reasonably sure most of the questions pertaining to vaccination, DMAs, and stage of MS must have been answered with this. Dr. Lekha, there are questions related to mitoxantrone. And the second question is, when do you stop the disease modifying agents or switch them over to something else? These questions have come up.
So I don't give mitoxantrone, and I don't see any need to try mitoxantrone in the current scenario when you have aggressive alternatives to try, which is much, much safer. Professor Singhal, if he was here, he would have told you out of the a small number of patients he treated with mitoxantrone and he published, he told me that at least 25% of them later on went to develop treatment-associated leukemia, I think, treatment-associated of some form of malignancy, and cardiotoxicity and so on and so forth. I don't think we need to consider mitoxantrone in the present scenario at all. So I think the older concept of treating with platform therapies, then escalating to stronger medications, I think people are moving away from it. You know, at the onset, if the patient comes to you with aggressive disease, which again you would define by the number of relapses in that short period of time, the lesion load you're seeing in that patient, young pediatric onset or borderline pediatric onset MS, which is again much more aggressive in terms of the relapse rate and the lesion load, I think you can straight away start off with an stronger medication, a second liner, rather than stick to you know, these interferons and glatiramer acetate, which are fading away. Literally, I keep saying they're like ambassador cars. They take you from point to point, but definitely not going to do the job the well as it should. And we also now know that no evidence of disease activity, NIDA3, NIDA4, they fail miserably after the first few years. So therefore, there's no point in giving them medications of that sort when you have more superior alternatives. And people like me, again, I come back to the situation I work in. I find that rituximab and other anti-CD, I mean, that's the only anti-CD20 molecule that we have right now, which is the generics are so affordable and we get them at very competitive rates. I think Netravati would agree with me that rituximab is affordable considering, I think for you, probably in Netravati, it is free in your hospital, maybe.
Yes, the
Yeah.
first two doses we get free for many of our poor patients.
For me, I get them very subsidized at less than 50%. And therefore, that's a very affordable, aggressive treatment to give from the onset if I feel the disease is aggressive by my definitions and what is described as significant MS at onset. Otherwise, the first line the drug that I would go for is maybe dimethyl fumarate. But again, you know, I'm restricted by the fact that if a young woman comes who's just married or who's planning to get married, DMT starting with dimethyl fumarate is not going to help me really, because that is not going to be a safe option for her in her pregnancy. And that's where you get stuck, because I do not have a first line safe drug. And here's a woman who has had a number of relapses and she's come to me for therapy. So that makes it very difficult. And that's some of the times that I resort to drugs like azathioprine, because azathioprine is safe in pregnancy. Azathioprine given in mild to moderate MS at onset with a little bit of steroid help initially and subsequently tapering of steroid and maintaining on azathioprine. She can you know, she can go ahead, she can plan her pregnancy. Like as an earlier speaker had said, if her disease is mild at that point, maybe she can even skip azathioprine, but it is not an absolute contraindication to be on azathioprine while you get pregnant. Breastfeeding is safe. And then if by chance a disease escalates, then you're giving her an opportunity to consider higher therapies. This happens to me always. So when do I start? Change course. I am very, very much worried about the results of the interferon trials and all those, which have told us that earlier course correction is extremely important for later onset stability of disease. So as I said earlier, the patient while on regular medication with whatever drug you have given, first liner, and you find that there is definite history of breakthrough relapses while being compliant, and it's definitely at least 2 or more attacks. It may be episodic. Some of these patients do not have clear-cut attacks, but they continuously say that my leg goes numb, my leg periodically goes weak, and then I get better, but that nagging, niggling symptoms are there, and at least 4 out of 5 of them, if you were to do scans on them, you're going to find new lesions. So if you have new lesions on scan, and those are accompanied also by lack of freedom from symptoms, even if they are not necessarily new or dramatic attacks, I would still consider course correction in those patients and escalate them to a second liner. And my second liner, by virtue of no choice, is rituximab. I prefer that. I don't have patients who can afford anything else. So that's how I go. But that's a general trend. That's course correction is required very early, and whatever your patient clientele can afford, you can give them more wider choice than I can. And that's a way to go.
Thanks, Dr. Thanks, Dr. Lekha. There are several questions in the chat box and the question and answer box, which are personal and related to the disease of that particular individual. I don't feel at ease on discussing them on a public platform. I strongly recommend that if you have those questions pertaining to your own health or your own disease, you contact the doctor who's treating you and get those issues addressed. So I think we are at the fag end of the discussion, and I would like all the esteemed panelists to just give a 1 minute maximum message for the patients with MS on the World Brain Day, starting with Dr. Lekha.
So as an MS specialist, I think we are glad about the times that we live in the sense that when I started off 15 years, 20 years ago, there was such a hard time convincing even my neurology colleagues that this is the disease which deserves attention and these are disorders which are there in the community. Once I did my first population-based prevalence study for India, I realized that we are underestimating the impact of this disease and the prevalence of this disease. So even today, if you look at the modest prevalence that we've showed, around 8 per 100,000 with a 1.4 billion population, we have sufficiently large number of patients in the community. Unfortunately, most of them may not have been diagnosed, but there is hope for the future because newer generations of doctors are so much more aware of the disease, their ability to diagnose, and the familiarity with the topic is so much more than it used to be 15, 20 years ago. And therefore, I am very hopeful about diagnosis. Treatments are still challenging, but as Rohit was saying, the generics are helping us a lot. The subsidized and competitive pricing that the pharma industry is offering us, that also gives you reason for hope. So I'm very hopeful on the whole.
Thanks, Dr. Lekha. Dr. Dheeraj, what would you like to give it as a message on the World Brain Day to MS patients?
Well, on this World Brain Day, I think my message to all people with MS and the MS fighters, as we call them, is that we are at a very, I would say, positive juncture where MS is concerned regarding their treatments, research, and the future prospects of very new, exciting treatments. And I can clearly say that MS is now considered as a surmountable disease. We do not consider this as a very high, unachievable challenge as it was decades back. And with a kind of newer research coming in and exciting results of new trials, there's great hope in even reversing the damage which is incurred in MS. And what I would like to tell all people with MS is to keep their spirits high, let their spirits not be dampened by problems with MS, and to look forward with greater hope for getting their condition in control, because as also Dr. Lekha mentioned, there is now a good deal of understanding in our country, and a lot of people who are dealing with MS provide excellent care to MS patients. So the future is good for MS. That's what I would say.
Rohit, what would you like to say on this day?
Rohit is muted.
You're muted.
I would just say that the first thing there should be no negativity. A lot of people read, Google, they come with a lot of, uncertainty about their life, their career. I think this is like another disease. We have people who have diabetes, we have people who have hypertension, we have people who have heart diseases, we have people who have chronic kidney diseases who are on dialysis, but they live a very positive life. I think this is like any other disease. We've gone very far on this. People are doing very well on treatments. And I think they just need to stay positive. They just need to stay focused, and they have freedom to do anything in life, anything they want to be. And the science and the doctors are there to support. I think they should just be very positive about this.
Thank you. Dr. Tapas?
Yeah, what I can say is that there has been a paradigm shift in the management of MS. It is very much a treatable disease now. All we have to do is to be aware of this disease and capture the disease at a very early stage. So if you can initiate treatment at the early stage, we can have a very normal, we can give a very normal life to the patient by treating them appropriately.
Dr. Netravati?
I second most of the things what my previous panelists have told, especially what Dr. Rohit mentioned, that many of them are not scared when they're diagnosed with diabetes, hypertension, thyroid. I actually tell these to my patients, but the use of MS, and the moment they Google, they get scared just because of the hype around it. But what I would want to tell is, we know the illness much better now compared to what was there before. And there is a large armamentarium of medications which are available. And our aim is, as a MS fighter, as well as any patient, aim is try to contain the illness at the initial stages so that they will be able to lead a very productive, happy life. Otherwise, when they are, especially like what Dr. Dheeraj mentioned, the shared decision making. So that has to be there between a patient and a doctor, so that we know that they will be compliant with medications, adherence will be maintained, and they will be able to take the medications very well. And though there may be little bit of limited approach in few patients, lot of research happening, and many medications are going to be available in the future, which may address more better the symptoms. Thank you.
Thanks, Dr. Netravati, and I thank all the panelists on this World Brain Day to join us for.
Nirmal Surya for last comments.
Dr. Nirmal, sir, are you there, sir?
Yeah, I'm very much there. Thank you very much. I would like to say that there are a lot of gadgets for neurorehabilitation available to the people. Even if you have disability, there is a hope. You have so many avenues to make you better and get you back to the ADL what you require. So neurorehabilitation would be an integral part of therapy, medicine, though the newer and newer treatments are available, which will bring back the patient to the less disability, but yet early identification of the disability in any form, whether it is neuropsychological, physical, or speech and language or other, is prime, and early intervention could make the life much better. So don't worry, there are a lot of things available for you, and newer therapies and newer rehabilitation are going to work together to make you better. Thank you.
Thanks, Dr. Nirmal. And so in the end, apart from thanking the organizers for giving me this opportunity and the panelists for being so active in this discussion, I would like to say that nothing is happening more actively on the front of science and medicine as it is happening on multiple sclerosis. So I think you should believe in science and believe that maybe a cure for MS is not very far away. Let's hope it happens during our lifetime. Back to Dr. Beshram sir for further carrying on. Thank you very much.
Thank you, Sumit, and all the panelists. And I would like to also thank the print media and other media for taking part in this very important campaign. And as always, they have been very supportive and highlighting the important aspect of the disease. Now I request Dr. Meenakshi Sundaram for final concluding remarks.
Thank you, sir. Let me say on behalf of IAM, say a big thanks to all these wonderful experts to have spared their time to be here and educate our people. There are a lot of our patients who have logged in, and I'm sure they're all better educated now about MS. I think if there is something, I think the summaries have been done by the experts themselves, those on the panelists themselves. What I would only say is everything is getting better. We are, the technology is better, the times are better, science is getting better, medicines are getting cheaper. So have belief at any point, and as was pointed out, with all these things getting better, our abilities to diagnose the disease, Dr. Lekha did point out about the huge number of patients that might be going undiagnosed. So we're getting better. Everyone is getting better with better technology, with better knowledge. We would be able to tackle them better. And as Dr. Nimal Surya pointed out, even if there is a disability, unfortunately, that can even be tackled better with today's technology being available. So if there is one word that all of us here would agree upon and tell you, if to all these warriors, as Dheeraj said, the MS warriors and the MS fighters, is that don't lose hope. There is enough arsenal available with all of us to conquer the disease, and we'll soon be probably, there's billions of dollars worth of research going on all around the world, and we're hopeful of better and better times. So thank you all. Stay positive, stay safe. Thank you.
Thank you very much.
Thank you. Bye-bye. Good night.
Thank you. Thank you. Bye-bye.
Bye-bye.
Good night, everybody.
Good night.
Thank you.
Good night.
Thank you, Mansi.
Yes, sir. You're welcome.